Hello and good morning, everyone. I'm Dr. William Zogby, Chief of Cardiology here, and it's a pleasure to welcome you to our cardiovascular grand rounds today. This is a very special grand rounds today to introduce a special, renowned person and a dear friend over the years, Dr. Christy Ballantyne, who truly does not need an introduction in the field of prevention and atherosclerosis. He's truly dedicated his professional career and life for prevention, understanding atherosclerosis, trained in the basic sciences, headed many clinical trials, and actually he will share some of the latest with us today. And he has been an established investigator of the American Heart Association, has been continuously funded by the NIH since 1988. And I know Christy very well. Obviously, back to, we're not gonna date it, but it's in the 80s. But it is truly an amazing career because his accomplishments and acknowledgments have been so many and so numerous and so impactful in the clinical arena in addition to the basic science arena. His many accomplishments have included being elected as Fellow of the American Association for the Advancement of Science, the American Society of Clinical Investigation, and the Association of American Physicians. In 2012, he received the American College of Cardiology Distinguished Scientist Award for the basic domain. In 2014 and 15, Thomson Reuters recognized Christy as one of the world's most influential scientific minds. And he was on the top 1% of researchers more cited. In 2019, he was awarded the Baylor College of Medicine Michael E. DeBakey Excellence of Research Award. And he played a prominent role in the development of FDA approvals of drugs and biomarkers. With over 800 publications, Christy, in the area of atherosclerosis, lipid, and inflammation. He also served on the editorial board for Circulation and JACC. He's the chief of cardiology research at Baylor College of Medicine after serving a long tenure as an influential tenure as the chief of cardiology at Baylor. He's currently the director of cardiometabolic disease and prevention at Baylor College of Medicine. Christy, what a pleasure having you here. I'm glad your plane was on time across the street. And it is so nice to have you come and share with us the latest on the treatment and assessment of lipids and atherosclerosis. And we look forward for a lot of collaboration between the two institutions.
Thanks, Tom. It's always a pleasure to come back to Methodist. I've spent most of my career actually here. In fact, still have a lab upstairs on the 7th floor, which we will finally be moving sometime in the summer. The other thing that Bill didn't mention is, I had very good mentoring. I happened to work when I did my basic research, and I went into a lab with geneticist Art Baudet. And I was trying to figure out who should I work under. There happened to be this woman who I'd met named Huda Zogby. So I worked under Huda. And the other thing is, I'm not sure I would have stayed at Baylor Cardiology if I hadn't had Bill as my attending in the second month, because I had this rotation at Ben Taub, and turns out it was a critical care, combined CCU, pulmonary critical care, and there was no CCU attending. It was just a pulmonary attending. And so I was like, okay, how is this supposed to work? And they're like, I don't know. You take care of it. And so about 2 weeks into I was doing the CCU/consults because a fellow didn't show up. So I had both services, and then about 2 weeks into the rotation, the consult attending quit and went into private practice. So Bill showed up the next month, and I was like, okay, thank goodness, I've got someone I can, and as you know, Bill's a phenomenal teacher, and I felt like, okay, now I made a good decision to come here. Wasn't so sure at the beginning of it. All right, so it's been a really exciting journey in my career in terms of lipids and atherosclerosis. These are my disclosures. And let me start off with the update. I was part of this pathway in terms of, and this is not guidelines, this was a pathway, so some of this is expert opinion. But what's new in this consensus document? So it was going over, some of the newer therapies. What do you do with these things? What are the thresholds, value statement, combination therapy? Let's go through some of these issues. As you know, there are some newer agents. Our starting point is statins. We've had those. They're great agents. We've got ezetimibe. Those are both generics. We've got the PCSK9 monoclonal antibodies. These are highly effective agents. We have combination therapies. We have resins forever with it. And then we have bempedoic acid, ATP citrate lyase inhibitor. It's both monotherapy and as a combination therapy. And we have a small interfering RNA molecule, inclisiran, which stops the production of PCSK9, which is also highly effective and can be given infrequently every 6 months. And then we have an entirely new concept, is evinacumab, which inhibits ANGPTL3. It's a fully human monoclonal, and this can lower LDL even if you have no LDL receptor. So it's really very different in terms of our understanding of lipoprotein metabolism. So our guidelines have focused on statins because that is where the evidence was. Started in 1994, we have a tremendous amount of data, but since 2013 guidelines, which focused and kind of steered things towards a statin-centric approach, there's a tremendous amount of data on non-statin therapies, and this slide needs to be updated because we just had another study with 13,000 people. So that'd be 135,000 patients in trials using non-statins that have all shown event reduction consistent with LDL reduction. So because of the increased evidence, and basically these trials have getting LDLs to very low levels for the PCSK9 trials, and most of those focused on very high-risk patients. The recommendation that came out of these guidelines was a newer LDL cholesterol threshold. So if you have a very high-risk patient, if it's over 55, you should be considering adding non-statin therapy. It had been 70 in the past. This was a more aggressive approach because of the data that's shown greater benefit. Optimal LDL probably being in these trials 30 to 40 with it. So this is a change in the pathway. The other one is they changed the value statement. The price of the PCSK monoclonals had been $14,000 a year and it dropped to $6,000 a year. And also the thought that you have to go from high intensity, go to the highest dose, then add ezetimibe or a combination. Is also saying combination therapy from the early on or even the start may be a reasonable option. And there's been multiple studies that have come out recently, real world data suggesting that this approach is perhaps even superior than sometimes titrating up, particularly in older patients. There'll be a paper coming out in JACC, the next issue. We have an editorial in that. All right, so this is another thing is don't wait a long time to add something else. So this is one of the things, and you might even in some cases, if you have very difficult patients, hit them with 2 agents immediately to really get the numbers down. I think it's an approach that we've taken in hypertension for how long? I mean, when I was back, as you said, Bill, back in the 80s, we'd start off with one drug, go to the maximal dose, then add the second agent. Does anyone do that anymore? I don't think so. We've looked at this, and it's just more pragmatic as you go with 2 agents before you get to the top dose. Particularly if you can get 2 agents in one pill, it's helpful sometimes. So that's, I think, where we're moving towards with this field also. So this would be starting earlier and then also considering 2 agents to get their levels down. And it's also in high-risk primary prevention. Consider the use of ezetimibe. It's an inexpensive generic agent. Get further LDL reductions, particularly in people who are not able to tolerate the highest dose of statins. So some of these are based upon observational data and also other trials that have been done looking at treating to target. There was a very good study done in France and Korea showing that this approach, mostly by adding a ezetimibe, was superior than high-intensity statin alone. Now here's something I'm sure that this audience is happy to see, is that there's more approach in terms of what about subclinical atherosclerosis, not just as a marker for risk, but should we be using this in terms of the intensity of therapy? And so there were basically two things here, and which had been discussed before. It's reasonable if you're seeing somebody, and we particularly do this in older patients who come in, who have, and this is why people say, why would you get calcium scores in somebody who's 70 years old? I see people all the time who are referred for statin intolerance. We do a calcium score, and if it's a 0, I think someone had talked about the power of 0. Who was that, Bill? I forget. But if it's so, then fine, we don't have to worry about it. So it's still a very useful. You can defer treatment in these individuals or reduce the intensity of the treatment. But the other one that comes up is, what about the people who have high scores, and not just an absolute high score, but also an age and sex percentile high score. And we felt that there was sufficient data that you should be more aggressive with these patients. And in particular, the issue, if you had a very high score, so there was some debate about what this would be, but people like round numbers, so 1,000 should be treated the same as somebody who's a very high-risk individual, getting their LDLs down to very low levels with it. So it's a more aggressive approach. We haven't necessarily had all of the trials in this area, but I think it's one that most of us have been implementing in our practice. There is lots of data based upon risk, and most of these trials that we have done have simply shown that your intensity of therapy is dependent upon the risk of the patient, and so therefore imaging, which is very useful for risk assessment, can be used in terms of guiding. And I think that'll be the future of the clinical trials, as now the future randomized trials will be using imaging, particularly CAC scoring, because it's so easy to do with it. So that's a part of this pathway. So in terms of statin-associated side effects, this is a vexing issue that comes up with it. One of the first thing ends up being is this looking at what is the risk of the individual. We talked about this already. If they're a low-risk individual, lifestyle may be enough. There are some individuals we also use very low-dose statins, small doses every other day, even 2.5 milligrams of rosuvastatin, so half of a tablet 3 times a week. You'd be surprised what you can get with that, and particularly if you combine that with ezetimibe. So there are approaches. Make sure you're looking at things like TSH, other secondary factors, reassurance, and then keep trying. If you'll try another statin, try a lower dose in terms of this. Okay, so let's go to non-statin, though. This was one of the big stories that came out of the meeting, was the first trial that was done in people who were and statin intolerance, somewhat of a loose term. We'll talk about that. It was defined in this study, intolerance to 2 or more statins, or 1 statin if unwilling to attempt a second statin, or advised by a physician to not attempt a second statin. You could go into the trial if you were on very low dose statin therapy. So this is the CLEAR outcome study. It was individuals who clearly had the high levels of LDL cholesterol, so they needed to be on something, and they were randomized to bempedoic acid, 180 milligrams daily, or matching placebo. It was event-driven and duration-driven both. So 1620 primary 4-component MACE, 810, which is the triple MACE, more the traditional hard endpoints, and at least 24 months of follow-up for the last patient in. Now, people had to sign a consent that says, I can't tolerate these medications called statins, even though I know they would reduce my risk of a heart attack or stroke or death. And my doctor has explained, I'm aware that many patients who are unable to tolerate a single statin medication may also be able to tolerate a different statin or dose. And that is very important because most people can tolerate a different statin or a different dose, the majority. And then the provider also there had to be a statement signed also about this. So it was traditional, the three component MACE is MI, stroke, or CV death. There was a hierarchical testing, so you march through each of these, then fatal and non-fatal MI, coronary revasc, fatal and non-fatal stroke, CV death, all-cause mortality. One thing that was surprising to me is that it didn't take that long. Maybe it's not surprising. It was not that hard to recruit this study. There were a lot of people like this, and I think particularly more as, you know, as people search Dr. Google, and they end up with all of the horrible things that statins can cause for it. So it was between really the beginning of 17 to August of 19. So they recruited these people, and remember this right before the pandemic. So I think it was fairly impressive that despite the pandemic, they had complete assessment in 95.3% and vital status in 99.4% of patients. So well done study. This is the Cleveland Clinic group ran the study, and a lot of events in the study. So the characteristics, this is one of the few outcomes trial which has about half women. And part of this ends up is that women are more likely to have, this has been shown in real world surveys, to have complaints of statin intolerance. Also happens more commonly in older people. And as we get older, there are more women than men still living. So it's not that surprising that this is, I think another issue that comes up is our concepts of what do we do for older individuals. Our guidelines are quite laissez-faire, I think, and my personal opinion is they're a bit inappropriately so. The American College of Physicians has had a statement saying that, you know, really not sure what to do about people over the age of 75, and part of the issue is life expectancy. So if you take a look at Social Security, the median life expectancy of someone who's age 75 is 11.1 years. That's not a short period of time, so it's a little bit of I mean, I think this is maybe back when we were starting, Bill, you know, you might have thought 75, what's the point? But, you know, now people are living frequently into their 90s. So I think you need to be considering a little bit more the individual patient and just these guidelines of like, you know, we're not sure what to do. So the LDLs were, as you can see, quite elevated, 139, had 30% high-risk primary prevention and 45% diabetes. And HSCRP was a little elevated at baseline 2.3. Baseline statin use was about 23%. So about a quarter of the people were on some dose of statin. Now, the initial reduction was about, you know, 21.7%. What you can see is, and this is going to be the challenge in the future with trials, the placebo group started going down as the study went along because there was drop-in therapy. And as we get more and more data, we're going to have more and more, having placebo-controlled studies will be harder and harder for this. So by the end of the study, there was also a good reduction in CRP of about, placebo-adjusted about 25% with it. So there was a reduction overall. The primary endpoint and secondary endpoints were both significant. So a reduction hazard ratio of 0.87 for the 4-component MACE, 0.85 for a 3-component MACE. It's absolute risk reduction of 1.6% for the 4-component MACE. Fatal and non-fatal MI, a reduction of 23%. Coronary revasc, a reduction of 19%. Fatal and non-fatal stroke, hazard a reduction of 15%, fewer events, but notice that this did not meet significance hazards. If you look at the confidence intervals, it goes over 1. So this was the end of the, by the hierarchical testing, the end of it. So the next one, although hospitalization for unstable angina was reduced, there's not a p-value with that because it was, you know, you stop the testing at that point. Nonetheless, consistent with the reduction in revasc in events. No impact on cardiovascular death or all-cause mortality, and this has been something that's been seen more recently. I think when you have trials and you have very, very good background therapy, we're seeing less of an impact here on mortality, unless you make a very, very big reduction in events. Now, in terms of adverse events, if you look at leading to drug discontinuation, there wasn't much difference between the groups. So overall, tolerated about the same as placebo. New onset diabetes, no difference. So unlike some of the statin trials where there had been an increase, there is an increase in gout, about 1%. This was also seen in the phase 3 program. So it is an important thing if you're going to use this therapy. It's best to measure uric acid at baseline, particularly if somebody has gout. If it's elevated, then you may not want to use the therapy, but you certainly should remeasure it again at 4 to 8 weeks for that. Most of the people who got gout had an elevated level of uric acid at baseline, so that's a big predictor. There was also a 1% increase in cholelithiasis that had not been noted. The tendon rupture was a slight numerical imbalance, but this did not show up as much of a signal here. So that's somewhat reassuring. And that in both groups, the people who had tendon rupture were people who had previous history of tendon problems. So if you look at the various subgroups, there was a consistent benefit across the groups. Importantly, it's another trial where women, there's certainly no p-value for interaction. Women had the same benefit as men in the study. There has been some issues that come up with that. So what are the limitations? So the trial enrolled only patients with documented statin intolerance. The effects in other populations weren't studied. Now, the addition of other therapies narrowed the LDL cholesterol difference between bempedoic acid and placebo over time. And then there were some issues with the pandemic. Outcome data, I think, of 95.3% is good considering the pandemic. You'd like to see a little higher than that. Vital status was quite good, 99.4%. So I think where this does go, though, is that, we just came out, this is the thing, whenever you write a pathway or guideline, pretty much usually the next big meeting is out of date. So this one's already out of date because we now have outcomes data from that. And I think it's supportive that this is, an effective approach to reduce events in statin intolerant patients. We'll get to just a second more, though, and this was the paper that got published in New England for it. Now this is, I think, worth looking at because we like to have some idea of, what's the mechanism in terms of the benefit. So this was looking at the placebo drop-in compared to bempedoic acid, and you see it starts pretty early and it keeps getting further apart as you go along. And so if you look at the differences in LDL, and you look at, for example, over the time period, the whole period of the study, what you end up is about 26 milligrams per deciliter. And that would give you expected hazards ratio for 0.67 millimoles of LDL reduction would be, for heart events, it's about 0.846, and they got 0.85. So you can't do much more on the line in regards to the event reduction seen here was proportional to the LDL cholesterol reduction. And I think that's a very important theme as we get into why the focus was on trying to get to low levels of LDL cholesterol here. And this gets to where are we in practice. So we're part of the Gould registry, and it's interesting if you look at the perception and you ask the clinicians in the registry, what they thought is that most people saying you should be getting LDLs, certainly below 70. And most, in fact, were saying that it's better to get it down to, even down to 50. A lot of people were saying this is before the pathway. But if you looked at what was happening in terms of combination therapy, very little usage, 8.5% on ezetimibe. This was 3.1% on PCSK9, but these centers were because they were the lipid enthusiasts. In practice, it was much lower than that actually at the time for utilization. In Sweden, they had a registry that showed really great utilization of high-intensity statins, but almost no ezetimibe and no PCSK9 inhibitor usage. So it's interesting, if you look at so you see very little combination therapy in the Gould registry. Now those same clinicians, in terms of hypertension, 70% of the people were on combination therapy. So treating blood pressure, where people are focusing on getting the number down, 70% of the people are on combination therapy. And then, in terms of lipids, you have usually most of these surveys is less than 10%. They're both asymptomatic chronic conditions, so it's really, it doesn't make much sense in terms of the approach. What about treatment of diabetes? Combination therapy. So I don't know that our approach, so there's two issues that you look at, is one is efficacy and the other one is effectiveness. So, you know, we do our trials, so this gets a little bit to the question, you know, why are we not doing such a great job on lipids? Well, the numbers have changed. You have the issue of statin intolerance, you have the issue of adherence. One of the other things that comes up is the systems approaches. If you look at the quality metrics, so we have this, you know, which I'm not sure which ones you probably adapt in cardiology, Bill, but the quality metrics we look at are blood pressure, it's 140/90. There's an A1C parameter, and then for lipids, it's about, is the patient on a statin? That's our metric. I don't know what y'all do here, but it's usually, if you take a look at NCQA and HEDIS and CMS, it simply is the patient on a statin. And then they have a second one, is there 80% adherence? Has anybody get their medicines at CVS or Walgreens? And have they asked you about mailing it? And, you know, you get this thing about they'll mail it every 3 months, right? So if they mail it to you every 3 months, how do I know if someone's taking their medicines, right? It just comes in the mail. So that's just, for that to be a quality metric, it's just ridiculous is what it is. It makes no sense. I mean, you know, you don't know if they're taking the medication unless you measure the LDL. Can you imagine having a blood pressure metric is that you wrote a blood pressure medication? I mean, so this doesn't make much sense. So in the New England Journal of Medicine just had a thing out about universal quality metrics, chronic conditions. They mention blood pressure, they mention diabetes, they don't mention cholesterol. So part of our problem is really, it's a systems approach that is not evidence or scientifically based anymore. And it might have been 2013, but the quality metric should not be just taking a statin. That is not correct. And particularly, it's really, you know, was it prescribed? Because you don't know if they're taking it or not. Even if they pick it up at the pharmacy, doesn't mean that they're taking the medication. I mean, I cannot tell you how many times in clinic I always work with fellows and someone's numbers are, you know, way off, and it turns out, well, yeah, I did run out, or, you know, this happened or that, or I just haven't been taking them. When you ask further with it, and people are always like, well, they're resistant. No, they're not resistant, they weren't taking it. So it's a very fundamental issue. We had a joint paper that was published by the ASBC and the NLA arguing that we have got to get back as measurement of lipids and LDL cholesterol as a quality metric. And hopefully we can get that to the future. Now, if it's about LDL, so this question comes up in terms of bempedoic acid, you know, if you're going to use this, it comes as a single or combination tablet. The combination tablet is giving a 38% reduction in this study, 40% reduction in this study. Ezetimibe also has evidence. So this would make actually, if someone's statin intolerant, this would make a little more sense than getting the just 21%. Why was the trial done with the monotherapy? The trial was done with the monotherapy because the FDA wanted to specifically test the hypothesis as what is the effect of this molecule alone in regards to efficacy and safety. So that answers that question, but I think in terms of clinical practice, this approach in combination therapy, or what would be the other thing, with even a low dose of statin, you know, and we mentioned even every other day, the more LDL reduction you could get in those patients, most likely the greater the benefit. Okay, so PCSK9, we have these highly effective agents. They're not used as much as we would like. We've got basically fully human monoclonals. We've got siRNAs, which block the translation. CRISPR-Cas9 may be a gene editing approach in the future that you do one-time shopping, and you have a lifelong reduction. And the other one is oral cyclic small molecule inhibitors. And so We have been involved with this program with a new agent, MK0616, and I had the opportunity to present this on Monday at the ACC meeting. So this is also another, the whole PCSK9 story is a fascinating story. It's something where genetics led to identification of a target, and then biotechnology can race in. When you see a loss of function mutation with a beneficial phenotype, fully human monoclonals, so that blocks the protein. The other one ends up as you go at the messenger RNA level of antisense oligonucleotides or small interfering RNAs. So I was told maybe a decade ago that I was consulting with a very excellent pharmaceutical that has strong clinical chemistry, that it would be impossible to develop a small molecule to inhibit the interaction between the PCSK9 and the LDL receptor because of the nature of that interaction. So what was fascinating is this story of a marriage of kind of biotechnology, screening processes with chemical chemistry. So a company had developed, it was called Raw Pharmaceuticals. They had developed a methodology for screening macrocyclic peptides displayed on mRNA, and you could screen up to 10 to the 14 compounds. And so in this high throughput assay, they found a molecule that would be useful to block the interaction. And now the medicinal chemist at Merck ended up modifying that molecule, and they looked at things like how do you improve the structure activity to get better PK, avoid degradation, avoid interactions. And they came up with this molecule that's shown in this figure, and then that was further improved. The phase 1 data was presented at the AHA, and this is the phase 2B dose ranging study. 4 dosages, 6 through 30 milligrams, a placebo, 4-to-1 randomization, 8-week treatment period, 8-week follow-up period. Interesting what's happening in at least some of the trials now. So this is just only a phase 2 study, but the point would be is, would an oral molecule, could it have a broader approach? Could you get it to more people? You know, even other countries where the whole thing of the parental injections, the refrigeration and the storage, it's easier to use pills. So there was a broad range of patients. Once again, half women in this study, which is unusual for a phase 2B study. And if you look at the breakdown here, you had a little higher percent Asian, 16.5%, Hispanic, 40%. So it was a broader, and it was also in terms of the types of patients. Clinical ASCVD was about 38%, intermediate to high risk, over half. Some of them were this borderline risk, and also a range of background therapies between high intensity statins, moderate, and no statin. So the results were that even at the lowest dose, 6 milligrams, a 41% reduction. But when you got into the higher dosages of 18 and 30 milligrams, these were basically the same as PCSK9 monoclonal antibodies. So and also the other thing that comes up is kind of going beyond LDL cholesterol. It turns out, particularly when you see higher triglycerides, that the better markers for risk are non-HDL cholesterol and ApoB, and it was highly effective. ApoB reductions up to 51.8% and non-HDL 55.8. And obviously, if you reduce LDL and non-HDL this much, you get more people to targets with it. Safety looked good in this study. The discontinuations were about the same as placebo. Nothing seen in any organ system. So very promising results. Limitation, it's only 8 weeks. So but it's the dose ranging studies are designed to figure out, can you do a phase 3 and what dose do you use? That's all being planned, and it was announced that there's going to be studies starting in the second half of the year, the phase 3 program, and the looking at also an outcome study. So this was published online in JACC. All right, we've covered LDL. What about LPA? So a lot happening in this area. LPA is very important genetic factor. It's frequently, you don't pick it up with a lipid profile. You have to actually measure it. And it ends up being very important, in particular, when you see premature family histories, we see there's about 90% of this is genetically determined, and it's going to vary depending upon different races. We'll see that black individuals have the highest levels. Second would be South Asians for this. So there's a lot going on again with this. You've got an antisense, the ApoA1. This is the LPA Horizon trial. Now that is fully recruited, so it's an outcome study. We're recruiting the olpasiran trial right now, the Oceans A outcome study. This lowers LPA levels over 90%. If you've got people with very high LPAs, and it's over 200 nanomoles, then we'd be happy to enroll them into the study. It looks to be very well tolerated. There's actually another one by Lilly that's in the pipeline too. CETP inhibitors. So this was an area that, it's been an exciting area, Bill, but I think we've had probably about as many failures as successes. These were all failures in terms of drugs that did not succeed with an outcomes trial. They were large studies. There was no benefit. There was actually harm in the first one, the torcetrapib study. So it's been a very difficult area. The thought was that you would try to raise HDL cholesterol with a CETP inhibitor. HDL cholesterol levels are not telling much of the story of HDL functionality. And so what ends up happening is the REVEAL trial was the last one, and it did show some benefit, but it looked like all the benefit was related to the reduction in LDL. LDL cholesterol and ApoB. It had nothing to do with the increase in HDL cholesterol. So there is another one that's in the pipeline. It's called obicetrapib. And this lowers LDL cholesterol about 50% on top of a statin. So it's quite effective. It lowers LPA also, which is interesting in terms of the potential benefit of the molecule. Right now, the only agents that we have that lower LPA are the PCSK9 inhibitors. Statins don't lower LPA, ezetimibe does not, bempedoic acid does not. So this is also ongoing with trials. HDL infusions. We have failed with mimetics, with a Milano pilot, the CARROT study. None of these worked. There is the concept of HDL functionality versus HDL cholesterol level. I know y'all are studying this at Methodist because it's a very complicated area. Henry's been working on this for a long time, but the issue of reverse cholesterol transport and anti-inflammatory properties of HDL may be the more important aspect of the lipoprotein. And there's frustratingly people confuse HDL cholesterol with high density lipoprotein. That's the cholesterol content of the lipoprotein molecule. There's a lot happening with an HDL particle as compared to many, many different proteins, phospholipids. There's cholesterol and there's triglycerides in that lipoprotein. All right, so there is a trial that's ongoing. Now this is intravenous formulation. Now this is native ApoA1 purified from human plasma. So this is the AEGIS 2 study, and this should be reading out at the next ACC meeting. Okay, triglycerides. We didn't talk much about triglycerides. And the first thing is that, and we were just talking about this before we started here, that lifestyle makes small differences on cholesterol. It makes tremendously large differences on triglycerides. And what are we talking about? So we're talking about, when you get over 1,000, that's very severe. You got to worry about pancreatitis. So that when you see these types of patients, we always have a discussion about, lifestyle and what are triglycerides. About 98% of patients have no idea. It's 3 fatty acids with a glycerol molecule. Then we get, well, what are fatty acids? In fact, if you look at your food labels, what is fat, protein, carbohydrate? It's just, even people who are medical backgrounds, it's very surprising when you ask them how many calories are there in, gram of protein. They're like, I'm not sure. I mean, what is a protein for? You go through it and so it's 4 and carbohydrates 4. They usually get carbohydrates for energy. You say, what about fat? How many calories per gram of fat? And what? 9. It's 9. And so what is fat? What is the calorie? it's a unit of energy, right? So fat has your most energy for anything that you take in, and basically it's a preferred energy substrate of the heart, fatty acids. So that took, how long did that take? 60 seconds? But so we go through, and then I always get them to stand up, press on their, make your stomach muscles as tight as you can. They do that, and I say, I can feel the muscle right below the skin, but what's underneath there? So, but under the rectus abdominis, you've got a lot of intra-abdominal fat, right? And what does that do? Well, it releases fatty acids to the liver, but so you end up with, you have a problem with your energy metabolism. Glucose and high triglycerides, it's not by chance that they go together. You have a defect in energy metabolism, and everybody says, I knew I had a problem with my energy metabolism. That's why I gained all this weight. Yes, that is right. But but then you go back with, okay, if you were going to try to eat two things less, what would they be? Oh yeah, maybe carbohydrates and fats. Yeah, that's a good start. And what else could you do? If you have a problem in energy balance, burn up more energy, right? Exercise more. So, that's a fundamental principle. Doesn't take long to explain it, but very few people know this despite having had a lifelong high triglycerides with it. Alcohol, as Henry did a study years ago, but we do postprandial studies. If your fasting triglycerides are 200 and you eat a high-fat meal, that may go up to 600. But if you want to really see something dramatic, you give the fat load with an alcohol. And Henry showed this. And so how often is that experiment done in Houston? Well, it's done every Friday night if you go out to the Mexican restaurant, and some cervezas and margaritas, and then you get the refried beans and chips and the enchiladas, and so the triglycerides that might have been 300 can go way over 1,000. And if they do it again, to have a big weekend, they end up in the ER with pancreatitis because somebody. So this is why we worry about even a triglyceride of 500 fasting. That person, if they just have a wreck of a weekend, can shoot very high. But if your lifestyle, Henry did show that if you eat a healthy meal and have some alcohol, it wasn't as bad, right, Henry? So, if you're going to drink, then eat healthy. So that's not supposed to be the recommendation, but it's still better. So severe high triglycerides is you're trying to lower triglycerides. Okay, that's the major focus. And then you've got fibrates, omega-3s, high-intensity statins, because most of them are high risk for heart disease. With it, lifestyle, weight loss, very effective, and we have new agents for weight loss that are spectacular. The alcohol cessation, very, very, very important for some individuals, particularly the ones who say, how many drinks do you drink per week? And they go, it's probably averaged about 2 a day. Then you say, well, when do you have them? Say, well, I have them all on the weekend. So, they get the 2 a day might be 3, but the 21 drinks are on Friday and Saturday. And that's the person whose number is going to really skyrocket for it. So we have the approach in mixed dyslipidemia. So, most people are not over 500. They're between 150 and 500. So here, the approach ends up being is statins are pretty important because those are, what you're going to find is they have high risk for heart disease. So lifestyle, statin therapy, and this is where you need a higher dose statin to really drive triglycerides down. Atorvastatin and rosuvastatin are the best for this. And now we have some approaches, but you're trying to get the non-HDL cholesterol and LDL down for this. There is the consideration. We have one agent only that's shown benefit. It's icosapentaenoic acid. So you have some considerations as to drive down LDL and non-HDL cholesterol. And then also you can consider icosapentaenoic acid here. Now, there's a lot in the pipeline here, particularly for these very severe patients. So we have, there's an ApoC3 inhibitor. It's antisense oligonucleotides. We're doing trials also with the olezarsen. There's an siRNA, which is Arrowhead has producing that. It's very effective. ANGPTL3 inhibitor also is effective for this. And there's an FGF21 analog that looks promising, and that has a big effect on NASH in addition to triglycerides. Okay, so where do we stand right now? Well, the focus mostly is on atherogenic lipoproteins, and so that's mostly, we think of LDL or non-HDL or ApoB. So we've got a lot that we have available. We have more in the pipeline here. We talked about statins, ezetimibe, PCSK9 inhibitors, inclisiran, bempedoic acid. ANGPTL3 inhibition lowers LDL, non-HDL ApoB very effectively. We'll have to see if it works out for events. In terms of triglycerides, there's also, we mentioned in the pipeline quite a bit. LPA, very hot area. Outcomes trials are in progress with more agents that are being done. We didn't get into anti-inflammatory. We're doing an anti-IL-6 trial with it. I would caution a bit about the paper that was in Lancet. They took people who were in high triglyceride studies, and they showed that LDL cholesterol didn't add much. If you have a high triglyceride, to get in those trials, you had to have been treated with high intensity statins. LDLs were about 70. The triglycerides were about 250. You should never look at LDL in those patients. You should be looking at non-HDL cholesterol and ApoB. So right off the bat, showing that LDL doesn't predict much is, a little bit of, okay, you looked at the wrong thing in terms of lipoproteins in the first place with it. CRP, I think CRP is a good marker. We have the data on colchicine, we had the data on canakinumab, we'll find out more about that. And there's the inflammasome inhibitors, which are in the pipeline. They're a little bit earlier up. We're looking at things like CHIP, clonal hepatopoiesis of potential in older people, maybe being tied into inflammation and high cytokine production. A lot in the pipeline. I always got to put a plug in. We do a lot of studies. We have a lot of trials opening up. We've got trials with high triglycerides, with this ASOs. Nothing gets stopped. It's 3-to-1 randomization, so 75% chance they end up active therapy, either for very high or 150 to 500. One of these will have a CTA component. There's very high LPA in clinical CVD, an SRA outcome study. We have an FH study with obicetrapib, and there's always new things happening all the time. And I will stop there and open it up for any questions or comments or things that are coming up in your practice. Thank you.
Christy, that was superb. You covered basically all the grounds of lipid issues, management, the future. Please, if you're online, just send a text. You have them there in front of you, or chat with us. I'll start with a question. Now that we have many different options of lowering LDL cholesterol, is the lowering of LDL cholesterol, and we know what the advantages are of statins, but if you take a look at just the simple way of, if I lower LDL cholesterol by so much, are they equivalent?
Yeah, so right now, the ones that we have approved, they're all kind of going through the same LDL receptor-mediated pathways. Statins increase LDL receptors, ezetimibe increases LDL receptors, PCSK9 inhibitors basically allow you to recycle LDL receptors, and bempedoic acid also blocks cholesterol synthesis, which increases LDL receptors. So they've all been the same pathway. So I think that for those, Bill, they're all the same, but they're all kind of working in the same pathway. When you get to something like ANGPTL3, that's a different pathway. We don't have that information. We've never had an outcome study that way. And then, there's still some questions about with the CETP inhibitors, it's a little different pathway. So it worked in the REVEAL study. We had some that didn't work for that. So I can't, I think if it goes through the LDL receptor pathway, and we have many ways of, increasing that, it seems to all giving us the same thing. There's other things that were done in the past that didn't work, and dextrothyroxine a long time ago, that was a different pathway probably, and also it had off-target effects.
Statins have been, touted also as stabilizing the plaque,
right,
in addition to some antithrombotic effect.
So that and that's the issue. Could there be a little extra with statins? But it all seems to fit on about the same line about the amount of LDL reduction. Now, once again, that probably is all having to do, how much are you revving up that pathway with it? Yeah.
Christy, congratulations on a wonderful career and one of the most important aspects of health care, coronary artery vascular disease. You've devoted your life to that, so my hat's off to you. The biggest problem the clinician faces is the cost of these secondary drugs. It's nice to say add this and add that, but it's very difficult to get approval at a reasonable cost to add this and that. So one question is, do you have any tricks? The second question I have is, if you have a patient who is inadequately controlled with a statin or statin plus ezetimibe, would you now add a PCSK9 inhibitor or a bempedoic acid pill?
Yeah, so that's a great question. I think that's one of the things that comes up is you would expect, since ezetimibe is generic and easy to prescribe, if we had a lot of utilization of that, I think then I would say it's just the cost of the drugs. But we don't have much utilization of ezetimibe, so most people are not looking to add the second agent. Now, this is one of the things that's been so disappointing is the high price of when they came out with this high price of the PCSK9s, and also the inclisiran price. It's been very frustrating because it has been, I was going to say a pain in the what, but a lot of our patients are sent to us just because it's like, we want you guys to do this because we don't want to waste time on it, because it's a frustrating experience. So there are key words you have to put in the document, and it's like the patient has clinical ASCVD, prior MI, recent LDL was, 85 over, which is on maximally, it has to say on maximally tolerated statin therapy. That's like the magic word. You need to have an LDL within a month. You need to have the clinical indication. Has familial hypercholesterolemia. If you put in there it has an LDL of 250 with a family history of premature heart disease, denied. It has to actually say familial hypercholesterolemia. The other one, which I would say, that's the straightforward part. Now the trick one, I don't say it's a trick. So the same thing is if someone has a calcium score who's 45 years old and they got a calcium score of 600. So I put they have extensive subclinical coronary atherosclerosis on that, and I think they do. I mean, that's what the imaging is showing. But if you don't mention that, if you just put they have a calcium score of 600, they will not do it. If you put down they have extensive coronary atherosclerosis, then we're getting most of those. So I think that's. Are you doing this also? I mean, I think it's fair to do that. Now, if you do a CTA, you actually would have documented that they have, luminal changes. But I think the coronary calcium score is just as predictive. So, that's to me. Sometimes I'll get calcium scores as documentation as to why they merit this, and it's a very inexpensive test compared to the cost of the drugs.
Thank you for all your work and all the lives you've saved. Probably a bunch of our South Asian people have gotten saved by your work. Two questions. One is, in the systems of care, I've always wondered if there's a role or opportunity of home-based testing for patients, because time goes by, a year goes by, they miss an appointment, and they've never checked it. And my second question is related to risk and what is the latest recommendations for the South Asian population, knowing the metabolic syndrome and triglycerides.
Yeah, so I think there's two things that could be done. The other one is direct-to-consumer testing, because the grocery store near our house has a Quest lab in it. That if someone's going to shopping, they could just get their blood drawn or something. But it's a problem right now is that when you do cascade screening, so you see someone with a high LPA, and then you say, well, you should get your children checked. Unless they're in your EMR, you can't order the test. And it used to be I just gave them the lab slips and go get the labs drawn. But I can't do that. So the EMR, and then with the HIPAA regulations, it's not that easy. So I think we need to have something where we change this, there should be direct-to-consumer availability that somebody can just walk in to a lab and find out what their LPA is. And also, if they just wanted to get their labs checked up, you could just, and I think having something that's, I think for cholesterol or something that they, we've had some things, but I think this needs to be something that you can mail out probably too also to get something done that would be easy. So there are some things that should make it easier to get the measurements for people, and also to get screening for people for it. Now, what's the second question?
South Asian population and like the metabolic.
Yeah, so I think this is one where you got to clearly go beyond LDL cholesterol. So, I had to do a thing about when is LDL cholesterol sufficient? And I'm saying, well, it's never sufficient. I mean, you need so a lipid profile, you have LDL, which is not even measured, it's calculated. And the equation that's used, sometimes it's not a good one for it, but you need to look at triglycerides, HDL, and non-HDL cholesterol. And then you need to get an LPA level. You've got to get a glucose A1C, if you're worried about family history in South Asian. I like to get a CRP also. I mean, it's a little more expansive workup, not really much, but it's just, you need to have a broader view of cardiometabolic risk. And then family history is also extremely important with it. So I think that's a starting point, and then the other one comes up. And one of the things I think that Meth's done a great job is by having not only coronary artery calcium scoring, but also by having the CIMT and plaque measurements done in a reliable, in a way for screening, not for clinical. So the younger people, because I have a number of younger people where it's nice, particularly some of the women, but it's not unsurprising that sometimes you'll have 35-year-old woman and she's got plaque, and you have young people with plaque, so I can do a CIMT and then I'll follow it up with a calcium score when they get a little older with it. And you have both modalities for it. I've got people with 0 calcium scores who have bilateral carotid plaque also, and that's another interesting group. And they have family histories of stroke. So I'm like, okay, I need to be doing something here. So I like having both of these, and it's well set up here so you can get them for a very fair price too.
Christy, wonderful comprehensive insights, just piggybacking on what the discussion on the combination therapy. So at an individual level, I completely agree, like hypertension, combination therapy should be the forefront. Of course, cost and prior authorization, and thank you for all the advice, but has ACC and HA, and you've been part of the writing groups on the recommendation, considered the societal and population cost? Because if you're looking at a number needed to treat of 65 to prevent one event with the cost of $4,000 to $6,000, that means $1.4 to $1.9 million to prevent one event. When are we going to have more conversation on just pricing? We don't want to pay less, but no more.
Right.
That's critically important. And
So that's why I think the ezetimibe is the real. I mean, see, right now you've got very inexpensive. I mean, ezetimibe, the cost of ezetimibe to a healthcare system is basically, if you're going to look at this for healthcare systems, you need to look at really acquisition cost. But ezetimibe and statins are incredibly low with it. So it would really make sense from the systems approaches to be pushing more combination therapy earlier, because you wouldn't need to go to the branded medications very frequently. I mean, people forget is that, I published a study many years ago that 40 milligrams of rosuvastatin, when you added ezetimibe, 10 milligrams, you know what the LDL reduction was? 70%. So you can get, the PCSK numbers are fantastic, but if people will use ezetimibe and statins, even on moderate doses, you're getting 50% reductions. And so you could achieve a lot of this. So I think that's the issue where that should be kind of the go-to from the systems. You go for that first. And now once you've done that, you have really should be identifying fewer people who really have more of the genetic and high-risk conditions that would really merit the other one. But I do think I understand this is the tension. The insurance companies have a valid issue of making sure they've had appropriate background. The problem that comes up, we all see, is they just deny whatever you put in there. So, it's if they use it as an excuse just to not pay rather than as a proper funneling with it. I do hope that newer therapies, so the two oral ones we're talking about with obicetrapib and the Merck agent, MK-0616, I think both companies do understand that if they want to see something to really make an impact, they're going to have to make it accessible. And that has not been done. And I think it's also led to the pushback, because you do have to have cost effectiveness as a consideration.
So you're involved in a lot of clinical trials for lipid-lowering therapies. Do you think it's time to retire mortality as an endpoint, at least in the primary endpoints? Because it just, I would say, rather than having a 13% improvement, we could have a 20% improvement, knowing that there is no way in 3 to 4 years we're going to have an improvement in.
So, I think, so one thing that comes up is which is a little bit of the paradox, so this is one thing is that primary prevention, the primary prevention part of this study actually had pretty good relative risk reductions, and the mortality was actually more favorable. And I think the issue is when you don't have, if you look at the patient now who comes into a clinical trial frequently motivated, screened, so they're on dual antiplatelet, they're on a high intensity statin, in most studies with it, they're on 2 drugs for blood pressure, and now they're getting lots of good diabetes therapies. So, I'm wondering, is that really the patient we should be studying sometimes as compared to more high-risk primary prevention who'd have almost no background therapy? And I think it's a very good question in terms of trying to tease out this whole issue of how much more can you reduce the risk. Once you get into someone who's got advanced disease, it's not just lipids. There's a lot more going on in terms of atherosclerosis and thrombosis and, what's the myocardial structure and function for that, as compared if you were to move back on the process where it's mostly atherosclerosis, but that may be 10, 20 years earlier. So, and then you have the duration of the trials, which is a big problem, because nobody wants to wait that long when you have a patent on a drug. So I don't know, it's a good question in terms of, how do we get to the sweet spot of both the endpoints and the patient population that's tested.
Christy, before letting you go, where?
Over there, Bill.
Thank you, Dr. Ballantyne. Great presentation. I have a more general question. I congratulate all of the investigators for conducting these massive trials, enrolling a larger proportion of women. My concern is when we start introducing these agents that have very specific patient populations, statin-associated side effects, with there being some concern about the nocebo effect that's really been highlighted by very well, elegantly performed studies. Yet we still, in cardiology, for patients with cardiovascular disease or at high risk, these treat-to-target trials have not been conducted. The one you referenced was a fraction of the patient populations that we enroll in these trials, not even conducted in the United States. Part of my concern about these LDL targets and why they haven't been adopted as quality metrics is perhaps because we just haven't conducted the trials to treat the targets for CVD endpoints. I do think that we should be measuring these things, but I worry that we are complicating the picture with therapeutic inertia with so many different agents, and we still haven't just tried to target a specific LDL level in a randomized controlled trial.
Well, so you had this study that was done, but there's also been some other real-world studies done. The racing trial was one that was done recently. There's another one that was looking at real-world evidence in Poland, post-ACS. And so, the question that comes up is, do you have to pay for RCTs? And this is the issue of clinical effectiveness versus efficacy of a new agent. So the trials done now are testing efficacy of a new agent for it. But I do think as you have the data that more and more that there's nothing magical about a statin. See, the thought was it was just statins that did this. If it's not statins that are doing this, and if we have more and more studies showing that it's the level of LDL and non-HDL cholesterol, then what is the rationale for spending yet more money to study what you already know? You see what I'm saying? I mean, you've had these trials. Those were the trial that I talked about was one that was done, a multinational study looking to treat the target. Then you have these other studies that have been done right now, which are looking at combination therapies versus monotherapies to try to get LDLs down. So why not use, as was talked about by Kurum, is looking at the systems. If you see people with LDLs that are not treated and they're not on at least combination therapy, why do you need to wait? I mean, there's a thing that was done at the Partners. They just implemented this to try to get people treated. And Kaiser was doing this many, many years ago. So I don't think that you have to wait. This issue of levels of evidence, you know, a treat to target study by nature is not going to be placebo-controlled RCT, right? Those are real-world studies because you're usually going to be unblinded, or it's cluster randomization or something like that. So I don't know how many more things that we need to put in guidelines, at least when you're talking at least with inexpensive generic therapies. Do we have that for blood pressure? I mean, you know, in terms of we had some data, but I think we have about the same amount now to make that move for using this approach.
Before I let you go, one more question. Practical question. With now pushing targets below 70, closer to 50 or so, what is an optimal non-HDL cholesterol level?
So, you know, they're saying that for the 55, they're saying 85 for HDL, non-HDL, about 30 points higher for it. But, you know, I think the optimal level is probably, you'd like to be well below 70 LDL, and depends what the risk is of the individual. But
obviously,
if somebody comes in and they're running, I think the thing is what is too low. So I'm not concerned about. So yeah,
what is too low?
So I'm not really concerned about being too low when they go on a PCSK9. The equations that are used don't work very well, so you should be looking in that case at non-HDL cholesterol with it. But you know, I'm not that worried. I think optimal in the trials they were getting between 30 and 40 LDL, but maybe you could. More recent one came out again that the lower the better in it. So I think you just want to get it down. You do have the issue of cost, which is certainly for healthcare systems is an important one with it, but it doesn't really apply to, that doesn't explain why is there not much. First of all, statin utilization is not optimal, and ezetimibe utilization is extremely low. So I think that that can't be used to explain the deficiencies. And there's lots of things that came up. There was another one came out of Duke, just looking at diabetes patients at point of care, ways of prompting improvement of, you know, appropriate therapy for hypertension, diabetes, and lipids with it. There needs to be more thought. Salim had a thing that was a late breaker using the VA. He showed some improved statin utilization by just you know, yeah, well, the EMR really, we've just EMR alerts and individualized messages. So I think healthcare systems, there is more focus on, look at implementation strategies. So I think we get into this issue of clinical effectiveness versus just efficacy of an agent. But I do think that starts with, how can you improve something if you don't measure it? True. How can you improve lipid management if you don't measure LDL? So that's a fundamental, that's scientifically, there is no excuse for not having that as a quality metric. It just doesn't make, there's not a biological rationale that you can now say the surrogate is only, you know, was a statin prescribed.
Christy, thank you for a phenomenal update and even more importantly, a great discussion. Thank you so much.
Phil.
I love it.
It's been a lot of years. Hasn't it?